Hello, I'm Mattia Giovannini, a pediatric resident from Italy and the IACI Junior Member Representative for the Allergy Immunotherapy Interest Group. Today, we have the pleasure to welcome Jonathan Hourihane, Professor of Pediatrics and Child Health at the Royal College of Surgeons, Ireland, to discuss together a paper recently published in Pediatric Allergy and Immunology Journal entitled Severity and Threshold of Peanut Reactivity During Hospital-Based Open Oral Food Challenges, an international multi-center survey. Thank you for coming, Jonathan. Professor, could you please explain the rationale and the main outcomes of the study?
Thank you for your invitation. This is an international retrospective study looking at children who've had food challenges with peanut in diverse settings, including many centres in the north of England, my centre in Cork in Ireland, and the very famous health nut study in Australia. And there have been questions and concerns that rates of sensitization or dependence on skin testing or blood tests would vary around the world, but it turns out that with open food challenge as the basis of your diagnosis of peanut allergy, it seems very consistent around in all of these centres. Now, the caveat of that, of course, is that these are all Caucasian centres with mainly Northwestern European founder populations. So, because a lot of people in Australia come from Irish and British backgrounds. So within that ethnic group, there is real homogeneity of a diagnosis of peanut allergy when it's based on a food challenge more than when it's based just on a clinical history or on skin testing. So the Australian group, in fact, were children who were being screened to be part of a study, so the rate of reactivity in that group was very low. But in fact, compared to the Irish and UK groups, the features of their reactions and their blood work were all really very similar.
Thank you. According to the results, would you suggest a different protocol for the oral peanut challenge in teenagers allergic to peanuts compared to children?
That's an interesting point, because one of the findings in the study was that teenagers had more anaphylaxis than the younger children, and they often had reactions or more severe reactions at lower doses. Now, I think really you can tailor challenges a little bit, but I think for international standardization, which is an harmonization of what we're all trying to do, I think the protocols should stay the same, but you might just need to be a little bit more careful or observant of teenagers. I think one of the things about the teenagers is that most of them will have had reactions already, whereas the Australian group were babies who were having a diagnosis made for certain. Most of the older children were people who had high levels on skin tests maybe earlier in life, so I think their reactivity is a little bit different. But I would prefer to have the same challenge protocol, but with everybody's eyes and ears open at all times during the challenge.
Great. In your opinion, early immunotherapy to food have a role in preventing anaphylaxis later in life, and at what age should it be started to obtain a preventive effect?
Yeah, well, I think there's an argument going on now as to whether immunotherapy should be started very early, but I think for milk and egg allergy, there's still a high resolution rate for those children, so maybe not quite so early for those. With peanut allergy, if it starts early in life, it's going to be present for the majority for most of their lives. So, however, some of the modalities of immunotherapy are more difficult for young children. The epicutaneous patches are well tolerated. The oral is less well tolerated, but the oral appears to be more effective than the epicutaneous. And the sublingual immunotherapy, the studies are, I don't think they're big enough yet to be certain. So it is a case, I think, that when you have immunotherapy, your chances of having anaphylaxis on a further accidental exposure are lower. So that's a big benefit from the studies, because death from food allergy is so rare that using that as the sole outcome for immunotherapy, it's going to be not cost effective. So we have to look at other ways of improving the cost economic evaluation of food allergy, so that it's going to be about fewer cases of anaphylaxis, fewer hospital attendances, and more improvements in quality of life and social engagement for these children who suffer from social isolation, because that's the safest thing to do. So immunotherapy, yes. I'm not sure when to start. I think you've got to give the more benign food allergies a chance to grow away spontaneously. And then for persistent milk and egg allergy, once you've decided they're persistent, you should start.
Wonderful. So to summarize, would you please provide one or two take-home messages related to this study you recently published in Pediatric Allergy and Immunology Journal?
Okay, well, the study shows that peanut allergy is really quite a homogeneous, simple, stereotypical disease across the populations that were studied, both in young babies and in older children. And I think anaphylaxis being more of a problem in teenagers in a challenge, that confirms that they are a high-risk group. And we all know that in the community they are high risk, and we always thought that was because they were teenagers. But this study is showing it's because of their peanut allergy is slightly different, with lower dose reactivity and slightly more severe reactions. So there's 2 or 3 very good reasons to have a big focus of medical attention on teenagers with food allergies to make sure they're safe and can go about their normal social life properly.
Thank you so much for coming.
Thank you. Thank you.